I'm very glad to have this meeting, and we can discuss about this. My name is Nasir. I'm a radiology resident in Direct Pathway at University of Minnesota, and I'm going to talk about a little bit about EVAR, and then we will talk about branched and fenestrated stent grafts for suprarenal, abdominal, and abdominal aortic aneurysms. So AAA has a prevalence of about 3 to 10% in patients older than 50 years old. What is it? So aneurysm means basically increase in the diameter of the of an artery more than 50% of its normal diameter, and the normal diameter of the abdominal aorta is about 2 centimeters. So anything beyond 3 centimeters is considered by definition as an aneurysm. It's more common in men, it's more common in men who are smoking, and it's more common when there is atherosclerosis of abdominal aorta. Why we have to repair it? Because if it ruptures, it has a very high mortality rate. There is in 1996 there was data about the ruptured AAAs causing more than 16,000 deaths a year. And if AAA ruptures, there is about 90% mortality rate. So it's a preventable cause of death. And here is a table about the natural history. It's from a VA, actually, down from out from Minneapolis VA here, showing that if roughly the diameter of AAAs is between 4 and 5 centimeters, there is less than 1% chance of rupture. But if it goes beyond that, especially beyond 5.5 and 6, it's going to be very high risk of rupture, up to 2%. And then if it's beyond 7, it's going to be even up to 40% rates of rupture per year. And then I'm going to talk about very briefly about the value of the screening. There is a mass trial showing the benefit for the screening. And I have to say that a lot of these data, I have used Dr. Vaticancherry's presentation for SIR-RFS. You can easily find it in YouTube for abdominal aortic aneurysms. It was a fantastic presentation. So again, these tables are basically showing the results of 2 different studies for the value of a screening. And what I'm trying to show, you can take a look at the left-hand table. It's basically pretty simple, and it's very important to be able to share this with patients. If the diameter is less than 3 centimeters, no further follow-up is needed. If between 3 and 4.4 centimeters, annual screening should be done. And then if it is between 4.5 and 5.4 centimeters, Q3 months. And then if it's beyond that, or if there is a 1% growth per year, or half a centimeter per 6 months growth of the aneurysm, then it should be repaired. And the mass trial showed that the chance of aneurysm growth will be less, and then there will be a 50% reduction in mortality in men who have aneurysm and are older than 65 years old. So screening is important. How about small aneurysms? If the aneurysm is smaller than 5.5 centimeters, a lot of different trials, ATOM trial and UKSAT trial showed that surgery is not beneficial in terms of survival benefit to treat small aneurysms, and CSAR and pivotal trials showed that EVAR is not beneficial for these small AAAs. And then there's a recent Cochrane review meta-analysis that basically confirmed these results. How about open versus EVAR? So open surgeries, it's kind of a no-brainer that open surgeries will have more complications. So these two trials, ATOM and MASS trials, talked about basically compared open and MASS and ATOMs were about open surgeries, and EVAR 1 over, and DREAM trials were about EVAR. And what I'm showing here is that between 3 and 5% mortality was the result of surgery as compared to 1 to 2% mortality rates after EVARs. So this is in early time after these procedures. So if we compare the patients within the first months after these procedures, there's a higher mortality rate after surgery as compared to endovascular repair of AAA. But what happens when we go in long term? Actually, the data shows that the results are about the same if we go beyond 2 years. So doing a surgery is going to be exactly similar to doing an endovascular repair of AAA. Why is that? The important stuff is that there will be graft complications and graft ruptures, but more importantly is the lack of optimal medical therapy. So these patients back then, when these trials were being done about a decade ago, there wasn't optimal medical therapy when we compare it to the current practice. So it's very important to be able to, whenever we do endovascular repair, we have to follow the patients closely and take care of the risk factors of them: hyperlipidemia, hypertension, diabetes, smoking cessation. All of those need to be done, and doing EVAR is not end of the story. So the disease process is still there, and it needs to be taken care of. So part of the presentation today and part of the basically agenda that we had was that Brandon was going to talk about statins and hyperlipidemia. So I'm going to ask him to continue and talk about medical therapy, and then we can go on and do our journal club after that. Brandon?
Okay. Yeah, so I'm going to just change myself over to the presenter mode. See if I can. You guys see my desktop?
Yeah.
Okay, great. Okay, so I'm going to just talk a little bit about medical management of AAA. This is this is a brief review. It's much more in depth, and Dr. Vatican Cherry has a great presentation that's on YouTube already about all of the AAA trials and the best medical management trials, including even discussing like the role of antibiotics in management of AAA, which is kind of fascinating. I didn't get into that at all, but I'll briefly talk about medical management of AAA, and we'll go on to the new 2013 American Heart Association, American College of Cardiology guidelines on statin therapy. So basically, as Nasir alluded to, a large reason that patients die and long-term mortality results are equal in open versus endovascular therapy is that there's a high chance of cardiovascular disease in these patients. If you look at the UK SAT trials, the UK small unit, 2/3 of the 496 deaths in the trial were attributable to cardiovascular disease, which is an astounding number. Actually, I'm just going to try to mute. I think there's someone who's not muted right now. Hold on one sec. Okay. Hey, Tim, I just muted you just briefly. And we look at the DREAM trial, 58% of the deaths were due to cardiovascular causes. And, looking back, one of the reasons this may be is because less than 50% of the patients were actually being treated optimally with medical management back then during that trial time. Then we look at the National Heart, Blood, and Lung Institute trial, and 416 of the nearly 5,000 patients who were screened had AAA, and they found that these patients had a significantly higher cardiovascular disease mortality rate. Patients who had aneurysms had a significantly higher cardiovascular disease mortality rate as an independent risk factor. It was an independent risk factor for cardiovascular disease mortality, and the cutoff for aneurysms that they used was 3 centimeters for females and 3.5 centimeters for males. So female with 3 centimeter aneurysm has a basically coronary artery disease equivalent, and if male, same thing with 3.5 centimeters. So basically these trials really show that having a AAA is a coronary artery disease equivalent and should be really treated appropriately if we're going to, reduce mortality in these patients. So how do we do this? Smoking cessation, as Nasir talked about a little bit, is definitely key. In addition to, high mortality from COPD and lung cancer, it's associated with a higher rate of rupture and 20% faster growth rate if patients continue smoking, patients with aneurysms continue smoking. A little bit about the JNC8. I'm not going to talk about it, but basically we had another journal club on JNC8, hypertension management, and you can review that, I guess, at a later date. But, definitely having optimal blood pressure control is important in cardiovascular disease risk modification. ACE inhibitors, the HOPE trial randomized patients with RAM, put them on ramipril versus the placebo, and there was a significant reduction in cardiovascular event rates, and mortality, especially in the patients in the peripheral artery disease group, which included AAA patients. So an ACE inhibitor is not a bad idea in patients with abdominal aortic aneurysm. Also, beta blockers, while there was a trial that really didn't show a reduction in mortality, a lot of the patients couldn't tolerate the beta blocker therapy. So that may have been a reason why it didn't show a benefit. But, it's definitely beneficial in patients who have obstructive coronary artery disease. So that's also another therapy to consider. So really what we're going to talk about today a little bit was the new 2013 cholesterol guidelines. And basically this was a follow-up to previous guidelines that we were all familiar with. We learned about likely in medical school. And basically it's a review of all the randomized controlled trials out there, all of the meta-analyses and reviews of randomized controlled trials, and they tried to come up with evidence-based guidelines, updated evidence-based guidelines for treatment of cholesterol. And so basically they identified some problems with the prior treatment algorithms which were addressed in the prior American Heart Association, American College of Cardiology guidelines for cholesterol management. And the primary management before these guidelines, these most recent guidelines were released, was to treat to a target goal. In patients with peripheral vascular disease, that would be less than 100 for an LDL level, and a goal of like less than 70 would be optimal. So the problems that they identified with this treatment strategy is that there's really no clinical trial data out there that would indicate, the optimal target, which was shocking actually to me. And also, basically, there was no clinical trial data out there showing that, one target would be better than another, like 70 is better than 100. It was all, supposedly, I guess, it would make sense that a goal of LDL level less than 70 is better than 100. But there was no randomized controlled trials out there. I mean, at least there wasn't a huge consensus of trials out there showing that there was one target that was more beneficial than another in terms of mortality. It also didn't take into consideration the potential adverse events from patients who are on multi-drug therapy, like myopathy, rhabdo, hepatotoxicity. So basically, if you're on a higher dose of statin, if you're on more drugs, concomitant drugs to achieve a certain goal, there's probably a higher risk of toxicities. So that's what they tried to come up with a new set of guidelines that would be more beneficial in this present day and age. And they really identified 4 groups of patients who would benefit from statins. And the first one that really primarily concerns us is individuals with clinical atherosclerotic cardiovascular disease, patients with carotid artery disease, peripheral artery disease, abdominal aortic aneurysm, renal vascular disease, mesenteric ischemia. So that's really our patient target group. The other groups they identified are individuals with primary LDL levels greater than 190 would benefit from a statin. Individuals aged 40 to 75 years of age with an LDL level of 70 to 189, and individuals without clinical cardiovascular disease or diabetes in that age group of 40 to 75 years with an LDL in that range, in the treated range, who have a 10-year risk of 7.5% or higher, 10-year risk of cardiovascular disease-related mortality. And they calculate that with there's this calculator tool that you can use. But really, our patients are going to be the individuals with clinical atherosclerotic cardiovascular disease. That's who we see. So certain populations that have to be addressed in taking statins are patients who are pregnant and patients who are nursing. Statins are definitely not indicated or not recommended in patients who are pregnant. And breastfeeding patients, there's a small amount of statin that is actually excreted into the breast milk, and so the potential adverse effects of that outweigh the benefits in terms of to the baby. So other special populations, individuals with New York Heart Association class 2 through 4 heart failure, and individuals undergoing maintenance hemodialysis. So there were 4 randomized controlled trials that specifically addressed statin therapy in these groups, and they didn't find that statin therapy reduced cardiovascular disease-related mortality. So based on those randomized controlled trials, which are the only ones out there targeting these specific groups, they said there was insufficient information on which to base recommendations for or against using a statin in these patients. So basically, it's up to you to calculate the patient's risk-benefit ratio. Okay, so basically they split statin therapy into 3 separate groups. High-intensity statin therapy, which is supposed to lower your LDL level by approximately 50%. Moderate-intensity statin therapy, which lowers your LDL ratio to from 30 to less than 50%, and then low-dose statin therapy. And so basically these drugs are grouped into these categories, and you can treat based on whether you want them on high-intensity statin therapy, moderate-intensity, or low-intensity. So basically, you have a AAA patient who comes into your office. He's not on a statin. So how do you approach this? You want to start a statin, obviously, because it's AAA is a coronary artery disease equivalent. So first things you do, you check a fasting lipid level, and you see whether they have any of these on the right-hand side of the screen. If their triglycerides are greater than 500, if their LDL is greater than 190, you want to look for secondary causes, which I'll get to in a second. You also want to check an ALT level, since statins can cause hepatotoxicity. You want to get a baseline of that. CK levels, basically, you don't necessarily have to check for a CK level when you're starting a statin, unless there's concern for increased risk for adverse muscle events. Like if they're going to develop a rhabdomyolysis or a myopathy. Basically, patients who have a history or family history of statin intolerance, a history of muscle, prior muscle disease, or there's a concern for drug-to-drug interaction, then you want to check a baseline CK level, because there's a chance that it could, there's a higher chance that it will be elevated from statin therapy. So basically, there's, if you find, when you check the statin or the baseline lipid level, and if you find that the LDL is greater than 190 or triglycerides are greater than 500, you want to think of other secondary causes of hyperlipidemia, of which there are many. And, I won't reference all the ones in this table, but basically this just goes to show there's a lot of those. And these are usually modifiable, or at least somewhat modifiable problems. So you want to address those before starting therapy as well. So basically, this is the main table in the guidelines, which are the guidelines are quite extensive, and they go into treating different types of patients. But these are our patients, the patients with cardiovascular disease. So basically, once you've done all the laboratory testing beforehand, before starting the statin, you break your patients into 2 groups, and those are patients who are less than or equal to 75, and those who are greater than 75. So basically, if they're less than or equal to 75 years of age, you're going to consider starting a high-intensity statin, which would be atorvastatin or rosuvastatin, as listed in that table. So basically, you can always refer to that table when you're going to start a patient on a statin. So if they're less than or equal to 75 years of age and they have no contraindications or conditions that would influence statin safety, which I'll talk about briefly, you're going to start a high-intensity statin. If they're greater than 75 years of age, you're going to start them on a moderate-intensity statin. And these are all grade 1 level, level of evidence recommendations. So characteristics that predispose individuals to statin adverse effects. patients with multiple serious comorbidities, including impaired renal or hepatic function, patients with a history of statin intolerance, patients with unexplained ALT levels at baseline greater than 3 times upper limits of normal, or patients who are on drugs affecting statin metabolism. These patients, you're going to, even if they're supposed to be on high-intensity statin, if they're less than 75 years of age, you're going to consider starting them on a moderate-intensity statin rather than a high-intensity. So basically, once you've started them on a patient on a statin, how often are you going to follow them up? Once after starting them initially at the initial visit, you're going to check a lipid panel in 4 to 12 weeks. This isn't, again, before we would be checking to assess whether we're reaching that target LDL level, but right now it's really to assess whether the patient is adhering to the medication. So if they're on a high-intensity statin, you would expect their LDL level to drop by approximately 50%. So if they're not, adhering to the medication, their LDL level is not going to drop, and you can address whether they're adhering to their medication or not. So basically, these levels of drop are really to assess for patient adherence. So, if at this 4 to 12 week visit you have reached the expected drop in LDL levels, you're going to continue to reinforce the adherence. You're going to check lipid levels every 3 to 12 months to continue to check adherence. And all of this is in addition to lifestyle modification, smoking cessation, moderate exercise. You want to definitely encourage that. So basically, if the response in 4 to 12 weeks is lower than expected, meaning the LDL level didn't drop as much as you expected, you have to figure out if this is due to the patient just not adhering to the medication or whether they can't tolerate it. And so this is basically the algorithm. This is basically what I was just explaining. This is the algorithm that's in the actual study, but I thought it was easier just to explain it in terms of bullet points. So during follow-up, basically, you want to keep the potential for statin side effects in mind. There is a small possibility that patients who are started on a statin, basically a statin can induce the development of diabetes. It's a small chance, but you want to continue to screen for diabetes, which is, definitely a cardiovascular risk factor during statin therapy. And there's also a rare possibility to develop for statins to induce interstitial lung disease. So you want to keep that in mind if your patient starts to become more dyspneic. That should be on the differential that the statins are causing. It's very, very rare, but it's definitely something that you want to have in the back of your head. Also during follow-up, so whether to check LFTs. So basically, you don't need to necessarily check LFTs on follow-up visits unless there's symptoms suggestive of hepatotoxicity, which we all know. They're listed here. Basically, if the ALT rises to greater than 3 limits, the upper limit of normal, and the patient has developed these symptoms, you're going to discontinue your statin. As far as checking CK levels, basically you don't need to check CK levels also on follow-up visits unless the patient starts to develop muscle symptoms. And basically, if they develop mild to moderate muscle symptoms like tenderness, stiffness, pain, which is very common for patients to develop when they're on a statin, you can temporarily cease the statin and assess whether it's actually the statin causing it, because it's important to discern a causal relationship. So, other things that can cause, symptoms like statin-induced myopathy would be hypothyroidism, rheumatologic disorders like polymyalgia rheumatica, and vitamin D deficiency. And so those are important to assess for, to rule those out and make sure that it's actually the statin causing the myopathy. If the patient is developing severe symptoms that are life-limiting, you're going to stop the statin and address the possibility of rhabdo, which can be pretty serious, causing renal failure. So you check a CK level, a creatinine, and a urinalysis to assess for myoglobinuria in case there's muscle breakdown. So that's really the statin guidelines. Dr. Vatican Chair, I don't know if you want to add anything, but basically that was pretty much what the document covers. So really the take-home point is this table right here, this treatment algorithm. Let me just pull it up really quick. This is really the take-home point. If you want to refer back to the statin guidelines, this is the most important slide. And then also going up to the types of statins, this is definitely a very handy resource to have. But Nasir, I think I'll switch back to you as being the presenter. Let me just.
Yeah, Brandon, I think you raised the key points. We're going to be following these aneurysms early, right? They may be 3-4 centimeters, so it's important to initiate them on the proper pharmacological adjuncts. Some may prevent not only aneurysm growth and rupture, but more importantly, as important or more important is to prevent heart attacks and strokes, which Nasir had said about 70% of these patients are dying from, or maybe Brandon, you said that, but regardless, 70% of these patients, even when you fix their aneurysm, are dying from this. So I think that's the key thing. As far as the myopathy, I don't know if there's any good curative process for that. A lot of patients, we just tell them to kind of just bear it, but also the different agents have different elements of myopathy. So the Crestor, the rosuvastatin, tends to have a little bit less myopathy than some of the other things. So you can try different statins when that occurs. But certainly a statin should be part of the algorithm for these AAAs or even peripherals.
Sure. Thanks a lot, Dr. Vatican, Jerry, and Brandon. And so we keep going with the journal club now. So AAAs, very high risk of mortality if they rupture, and most of the data is about abdominal aortic aneurysms. And what is important in the vascular repair, I'll just go briefly on this. So it's very important to have an adequate neck for the aneurysm. It should be at least 1 centimeter. And then it's very important to have an angulation. Obviously, it's better not to have any angulations, but then the angulation should be less than 60 degrees. So these are called bad or hostile aneurysms. And then this is as far as the infrarenal aneurysms goes. The topic of the journal club that we have is about the endovascular repair of the aneurysms that are infrarenal, meaning that the neck is short, or they are suprarenal, basically they are including the renal and SMA, or they are thoracoabdominal. And then the results and outcomes after that. It's important that this study is a multi-center prospective study, but it's going to talk about the early outcomes after the fenestrated and or branched stent grafts for aortic aneurysms. First of all, the prevalence is not really high. We're talking about 5% of all of the aneurysms that can happen in the aorta. And so the study setting was out of 8 university hospitals in France from 2009 up to 2012 on about 270 patients with 1 month of follow-up. The selection criteria was as follows. So AAAs of greater than 5 centimeters in men or greater than 4.5 centimeters in women, the thoracic aneurysm of 5.5 or 5, the infrarenal neck of less than 1 centimeters, as I showed in that schematic diagram, and then the target arteries greater than 5 millimeters. The target arteries meaning those like renal arteries or SMA or celiac, and iliac arteries of greater than 7 millimeters. They excluded the ruptured aneurysms, the myocardic aneurysms, and importantly, they excluded the patients who had life expectancies of less than 6 months. And then they grouped their patients based on the severity of this aneurysm, and basically considering the anatomical factors. The group 1 was basically the simplest group. They had a short neck and basically juxtarenal or pararenal group. The suprarenal was basically involved, the aneurysm was involving the SMA or celiac and also the lower thorax, the lower thoracic aorta was also involved. The G3 group was all the way up to subclavians, basically a thoracoabdominal aneurysm. So you can see very nice pictures of those. So the group 1, basically the simplest group, basically a short neck. The majority of patients were in this group, 180 patients, and then 42 groups in each of the group 1 and group 3. Group 2 and group 3. So group 2 meaning that it was suprarenal, all the way to the major vessels of SMA and celiac, and then group 3 all the way to the basically higher end of the thoracic aorta. I'm just showing here some figures out of the found this in Google, just to show you what we're talking about in terms of the branch grafts. And then these are basically the fenestrated grafts. I use it from a great presentation that Dr. Cherry shared with me. So these are the fenestrated grafts, and then basically this is, for example, a stent that will be in the renal arteries, and then it will be used for the fenestrated grafts. So back to the journal. So they group their patients, and then these are the results of the procedure. So mean duration of the procedure was about 3 hours. The immediate success rate, meaning that they were able to exclude the aneurysmal sac, was more than 90%, which is pretty good. And only a minority of patients, about just 8 patients out of 270 patients, had SMA or renal artery stenosis or occlusion requiring stent placement or angioplasty or bypass. And then about 3% had type 1 endoleak, about another 3% had type 3 endoleak, and 1/5 of the patients had type 2 endoleak in the early follow-up period. The complications, 6% of the patients required permanent hemodialysis. Spinal cord injury was present in 4%, but the good thing was that the majority, about 70% of these spinal cord injuries were not permanent. 11% of the patients required reintervention, and in-hospital mortality was about 10%. So these are pretty good results if you compare it to the literature. Basically, they are reasonably comparable to the literature that's been reported for AAA. This is a pretty busy table, what I'm just trying to show you is that just the average age was about 70%. The baseline characteristics of the patients was not different between these 3 groups of basically group 1, group 2, and group 3. Basically, it's showing that the hypertension, hyperlipidemia, diabetes, these kind of risk factors for atherosclerosis, they're all very similar except for coronary artery disease, which was actually more on the group 1 patients. And then the diameter of the aneurysm, the maximum diameter was about 6 centimeters in group 1 and 2, and then about 7 centimeters in group 3. Here are the results of multivariate analysis. So we're talking about the outcomes in the early period. It's basically about a month after the repair. The longer the duration of the operation, there will be a 2-fold increase in renal function impairment and 6-fold increase in spinal cord injury, and which was always translating to higher mortality. And if you look at the anatomical considerations, the more complex the patient, basically group 3 patients, had a longer duration of operation and therefore higher mortality. The other risk factors were peripheral artery disease and previous aortic surgeries, which would increase risk of mortality by 2-fold. and also a spinal cord injury would increase risk of mortality. Importantly, the patients who required hemodialysis had a very high mortality rate, and also the intervention would increase mortality by fourfold. So, in summary, the take-home points, they showed that at least in the early, immediate post-op period, there's a greater than 90% success rate. And the fenestrated and branched grafts are doable for these complex aortic aneurysms. Obviously, we need to look at the long-term data. That's important to look at in the long run after 1 year, 2 years to see what are the results. The important pre-op considerations is the anatomy of the aneurysm, as we showed that group 3 patients had the worst outcomes. Hello?
Hello.
And the important factors that the operator needs to be cognizant of is the presence of calcification or thrombosis in the renal artery and SMA. Also, the number of fenestrated is needed, and also the previous aortic surgery are the main determinant factors of mortality and other significant outcomes. Important for prevention of a spinal cord injury, CSF drains are being used, and in this study they used them also, which showed that it was helpful for preventing the spinal cord injury. They also are talking about a staged procedure, which basically they are using a secondary graft placement in some of the fenestrae or all of the fenestrae. Basically, a few days later, they take the patient back to the OR and put a secondary stents. And then placement of a perfusion branch in the aneurysmal sac, which basically they put this branch to be able to maintain perfusion to those arteries, and then they take it out after the day of the operation. So these are the different methods that they're talking about. Obviously, it's not randomized. It was per operator's decision to do these, and they're claiming that they were helpful for spinal cord injury prevention. I'm just going to thank you very much for your attention, and Dr. Vatican Cherry, if you can discuss.
So I had a question. If anybody knows the answer, why do you why does one think, because to me the biggest issue here would be that these are complicated procedures, and obviously the fact that the longer duration of procedure was associated with significant renal insufficiency and spinal cord injury, especially when those factors were linked with mortality. So why do we think that that the longer duration of the procedure results in that? Having not really done any of these complex procedures myself, obviously.
Yeah, no, I mean, I think you bring a valid point. I think if you look at the more complex aneurysms, they go higher and higher into the descending thoracic aorta near to the left subclavian artery. Mm-hmm. So as you're covering more and more aorta, that increases your risk of spinal cord paraparesis or paralysis or spinal cord ischemia. So I think that surrogate is probably a lot to do with it, So you're covering, the anterior spinal arteries and a lot of those intercostals that are all providing some of the supply to the spinal column. And then the other things that I think in this article that weren't cleaned out is it was operator preference, whether they put a CSF drain. Right. Whether they coil the hypo or preserve the hypo. And I'm not even sure if they did carotid subclavian for some of those type 1s. So those are concerns that I have in this trial. Though it's prospective, it wasn't. It was left to discretion of those, and so all of those things can be factors that can cause spinal cord ischemia or infarct.
Mm-hmm. So would you based on your experience, Joji, would you recommend that you put a spinal Spinal Tap on everybody, or?
Yeah, so that's a really good question. I think in the ones that are pararenal or juxtarenal, the likelihood is pretty low. But if I'm going up into the mid-descending, yes.
So
you're
above
doing
the diaphragm, basically.
Yeah, so yeah, I'm definitely if I'm doing a thoracic aneurysm in a prior AAA repair, my coverage is over 20 centimeters, or they have hypogastric disease or any of those elements. Those all contribute to spinal cord ischemia. So the left subclavian, the descending thoracic, the abdominal aorta, the hypogastrics all contribute to this process. So I think it's really imperative that in those patients you be aggressive about maintaining the MAP and dropping CSF pressure. So the key formula I think for these patients is the cerebral perfusion pressure, spinal cord perfusion pressure, and that's based on the formula of mean arterial pressure minus intracranial pressure. So you want to keep the MAP at least around the 80 or 90 range in general in these patients, and you drop the ICP at least for 24 hours in the 10 range, and then you can start to slightly go up as they're tolerated. And I think that's the key thing to reduce the risk of spinal cord ischemia. One of my residents kind of presented kind of the data, and most of the data is from open thoracic abdominal repair, looking at all these different factors. I think that's valuable to look at, but I think those two key things are key. So I think that correlates with what's going on with the study. That's a good question, though, Dave.
I was actually shocked that there was even in the juxtarenal and pararenal there was spinal cord ischemia. I just hadn't really thought that. I really I guess when we do EVARs, I don't consider it as much of a risk factor in patients with just infrarenal abdominal aorta, but I guess
no, you're absolutely correct. It can happen. Luckily, it's pretty darn rare in infrarenal aneurysms. But like I said, the hypogastrics do supply some of the spinal cord flow. The lumbars do supply it. So anyone who's had prior AAA repairs are higher risk, and now you're extending it, right? So the arteriodampcovitz or major spinal arteries can start fairly low, in the upper abdomen or, lower thoracic. So since there's a variable supply, and the more coverage of the aorta you have, the more risk you're taking. And these are longer procedures with potential hypotension, and those patients can't tolerate a prolonged hypotensive period. All those things are factors.
So if you were going to do if you were going to do a thoracoabdominal fenestrated, would you do it staged? Seems like that would be.
Yeah, so that's an interesting question. This whole concept of stage is a little bit it's a little bit beyond my understanding, in the sense that when I've only seen a couple of these cases, and in general when you're doing that, you need to really pinpoint the opening of the fenestration, or mainly the fenestrations with the renal arteries or the visceral vessels or celiac or SMA, as you're deploying it, and then you have to cannulate it and then deploy a stent, which can be the tough part, to cannulate and deploy the stent. So I'm a little bit surprised that they're able to deploy the stent and then stent it afterwards and then a couple of days later. So I would, in general, fix it. Now, the concept of leaving something in the sac, like another branch, and leaving it in the sac to perfuse those lumbars and what have you, is kind of an interesting concept in an unruptured aorta, seeing how they do post-operatively, and then plugging with the Amplatzer or plug or something in that branch is kind of an interesting concept. But in general, I would say no. I would say maintain the pressure during the procedure and afterwards, and keep a close eye on the MAP, and really dive in the numbers with some really good pressors that you can really manage. And then second is, CSF management as proper. And then third is if you have an ability to revascularize a subclavian or hypogastric in these conditions, do it. Or if the profunda is diseased, fix it. If the SMA's got a stenosis or celiac's got a stenosis, all these are supplying probably some element of that. So I think those are the key things. So, go ahead.
I don't know if I gleaned this from the method standpoint, but would you, so all these patients basically go to general anesthesia then, would you say? Or
so, no, that's a really good question. So in general, yes, because of the complexity and the length of the procedure. But if you look at when you look at the variability in techniques, and I think that's a key thing, some were done, so it looks at it, some were done with percutaneous Others were done with cut down. Some were done with hypogastric artery embolization. Others were branched and preserved. Some put in a spinal drain. Some didn't. Some put a temporary perfusion branch.
There's a lot. Yeah, there's a lot of stuff.
A lot of variables. So that's definitely, I think, a weakness of the trial. You know, you need to standardize your protocol, so you can't glean as much valuable data. But in general, I would say most of them are doing general anesthesia when you're doing these more complex branch or fenestrated. We're doing an endograft tomorrow just with local and sedation, but it's a straightforward percutaneous endograft. And my belief is that there's going to be a lower risk of incidence, right? Because I think general anesthesia itself, in my opinion, though it's not a great risk, adds risk because it's hard to maintain the pressure, there's shifts, there's a lot of physiologic effects that we don't think about, we take for granted.
So you think my point was going to be that during constant sedation, sometimes I have a hard time, the pressures kind of drop, variably. So I my impression was that with general anesthesia, you'd be able to control that better. But it sounds like based on what you're saying, that's not necessarily true.
No, it's not necessarily true. I think the key is to have pressors ready to go, as needed. So whatever pressors and antihypertensives you need, I think is really key in the angio suites or the lab, to kind of reduce those risks. You can have anesthesia support, but to minimize the general intubation is probably a good thing if you can.
So I have a question that just due to my lack of understanding. So the decision how do you make a decision versus coil hypogastric versus stent across stent
really
through
good
hypogastric?
Question. Really good question. I don't think there's a right or wrong answer for that. If you can preserve it easily, I think it's very reasonable to preserve it. But my bias is there was an article by Frank Vieth and Manny Mehta where they looked at over 100 patients who did bilateral hypogastric artery embolizations with really very little morbidity and mortality. In our own series that we've done, again, from a claudication, erectile dysfunction is pretty low, and a claudication, the majority, we did about a dozen or half a dozen to a dozen patients, and majority of them recovered their claudication symptoms. So buttock claudication was the main symptom. The key is to stay in the main main internal iliac artery branch and not go to the divisions. If you go to the divisional branches, it's about a 40% risk versus a 10% risk if you stay in it. And like I said, in my experience, most of the patients in the long-term follow-up have resolved their buttock claudication. So
in terms of the branches that go off of the cord too, are you worried about that in terms of the paraplegia or?
Yeah. So you're absolutely right. So if I'm doing more extensive aneurysm repair, thoracoabdominal, then we'd want to preserve that hypogastric.
Okay. Or would
and
you
definitely make sure the profund is healthy.
Or would you consider doing like a pre-op coiling, let it collateralize?
Yeah, so if I'm doing bilateral hypos, I tend to do that. I'll coil one side, wait 3-4 weeks, and then coil the other and stent graft at the same time.
I see. Okay.
That's usually we usually coil the hypogastrics, but I was from what I've read, I mean, correct me if I'm wrong, but type 2 endoleak, it doesn't necessarily always cause a huge problem, and like you could treat it afterwards if it does develop. But over following the patients over time, there's a debatable whether type 2 endoleak actually causes problems.
Yeah, so I mean, I would say about 20+% of my patients will have a type 2 endoleak at the end of the procedure. I almost never get excited about it unless the aneurysm sac is growing larger, because then that suggests to me is a surrogate that the sac is pressurized. So if the aneurysm sac is growing, then after endovascular repair, then you need to fix it. If not, you should probably leave it alone.
So that brings up an interesting point, because I thought, I was reading the long-term outcomes for EVAR repair first decade article that we sent out. I think they distinguished between, post-op type 2 and, longer-term development of type 2 endoleaks, and said that there was a worse outcomes with the type 2 endoleaks that, are, present like a year out, So do you tend to want to treat those more soon, or do you watch those, So,
yeah, that's a good question. So in general, I will still follow the aneurysm sac size.
Okay.
And now if it's like an 8 centimeter with a type 2 endoleak, then maybe and it's a big one, I may consider treating it. But in general, I'll just follow it.
I see, okay.
I see what the sac pressure is, It may still go away. So,
I had a question also, Dr. Cherry, about these different procedures that, so this is also, I think, was another thing that it was just by discretion of the surgeons or interventionalists in this study that, so they did some branched, some fenestrated. Is there, so do we know that how we can select which way to go, basically?
That's a really, really good question as well. So I'm not sure what the right answer is, but some people think when you have the fenestrated grafts, there's not as much flexibility between the aortic graft and the visceral branch, okay? And so the aorta is a very mobile structure, and the renals and the viscerals move a lot, right, with inhalation, exhalation, and whatnot. So there's some worries that will the stent grafts migrate or this or that, and there's some suggestions that maybe that occurs. Whereas if you have branch technology where there's a lot more mobility, a lot more give, it's maybe less likely to happen, but no one really knows. I think sometimes it's hard to know. It's a moving target, so we'll see where that goes. But that is a good question. So fenestrations versus branch, different beasts. Maybe the stent grafts that we use will be different and better. Who knows? I mean, we're not sure. The jury's out on that. And how the aneurysm sac decreases or regresses with time will also determine what happens in with the two types. So it's rather complex.
Yeah. There was just as a side note, there was I think from the same group, and it was an earlier study, and they were talking about the branched versus fenestrated, and they were reporting their data that they were so successful with fenestrated grafts. It was kind of a homemade kind of thing that they were using the stents with fenestrated grafts, because the companies that providing the branched grafts were just taking so much time for them to give it to them. So it was an older study, like 5-6 years ago. So probably these days the companies are like more actively being able to provide it. But it was out of UK, and they were saying that the fenestrated grafts were much cheaper than branched grafts, because just the company was just maybe taking so much time or spending a lot of effort to be able to make the branched grafts. So it's just as a side note.
Well, I think these grafts take a lot of time to custom build for the patient's anatomy. So they take the anatomy of the patient, the length of the aorta, the length of the angles of the celiac, SMA, the renals, the distance between the celiac and SMA and the renals, what on the clock does it come off on. So they measure all that out, and they home make these grafts in a broad, I think in Australia perhaps, where I think where Cook is founded. And so it takes time, and it takes at least 4 to 6 weeks for that to happen. Now they are working on some grafts that are going to be fit most people's anatomy. They've done studies looking at a bunch of CTs looking at these aneurysms and seeing what most of the celiac and SMAs come out right around 12 o'clock. The renals will come off at maybe 10 and 2 o'clock, so on and so forth. So by basing it on that and how far below and above, they can kind of fit a lot of people's anatomy, and you can have something that you can just get off the shelf. So that's something they are working on. But, this is a moving target, and things will change quite rapidly. So, yeah, these are really good questions, though.
This may be an obvious question, going back to the statin topic. So, obviously, the fact that you have a AAA one, so the fact that you have a AAA greater than 3 centimeters, that's in itself coronary artery disease equivalent, correct?
Right.
And does that constitute as a symptom, like a clinical ASVD or you know what I'm saying, like, or is that
Yeah, you're basically an atherosclerotic vascular disease equivalent. Yeah.
Okay.
So you should be treated accordingly.
They, in the article they distinguish between those that have arterial disease that aren't symptomatic, other than AAAs and stuff, but so they're, when we say AAA, we're saying like a clinically significant symptomatic coronary artery disease patient, basically.
Oh, I see what you're saying. I'm not sure if it's equivalent to like a symptomatic carotid or symptomatic coronary or it's an asymptomatic atherosclerotic person. I don't know how you would stratify a symptomatic AAA. Symptomatic AAA is going to be a little bit different beast.
Right. Obviously, it's not a symptomatic, but that's what I'm trying to get at. Basically, is you go automatically to high dose statin if there's no other contraindications in there.
I think that's very reasonable in that population.
Okay.
Because I think the ones that have like symptomatic carotids, it's a pretty straightforward thing because they're going to be the ones that are showering, so you want to stabilize the plaque. And those are the ones I would say are probably the highest benefit from high-intensity statin therapy because not only do the key is to stabilize the plaque, prevent plaque rupture, prevent embolization, of that plaque. And so that's why I think that symptomatic for carotids is a little bit different beast than many of the other patient populations.
I see.
So then as far as the article goes, I think a couple of key points is this was prospective, which is always better than retrospective, but it wasn't randomized. And I think it was a good feasibility study in the sense that the ideal thing is randomizing it open versus endo, right? And, the two operatives. Right now the gold standard is probably still open repair because that's been historically what's been done. But, these patients are all high risk for open surgery, so that's number one. So it's more of a safety and feasibility trial, and I think that's important when you're first starting the process, and that's where our IR always sits, right? They're patients unfit for surgery or in general. Right. And then you have to prove the safety and efficacy initially, and then ultimately you have to compare it to the gold standard. So if you look at, aortic valve implantation, first off they start with high-risk patients, then they're going to go for normal risk patients, just like carotid stenting, high risk for, that's SAPPHIRE data, and then CREST is comparing it to normal risk, that you're randomizing open versus endarterectomy versus stenting. So the same thing, may need to occur in here to really figure out what's to go. And then, again, when you leave all these things to discretion, especially high-risk things like spinal cord ischemia, and you don't standardize the algorithm, then, it puts that to chance. And who do you hypoembo or not, so on and so forth. And then, looking at the primary endpoint, which I thought was interesting, they looked at 30-day and in-hospital. Well, a lot of our percutaneous endovascular aneurysm repairs go home the next day within 24 hours. And so these patients, some of them were staying a lot longer. And so the in-hospital mortality was higher than the 30-day mortality. That tells you that patients were staying in the hospital for extended periods of time after these repairs, even though it's an endovascular approach. The other thing I thought was interesting was the rifle criteria, which was a way of stratifying renal dysfunction afterwards, whether it be less with a 25% drop, up to 50% drop as I, F is 75% drop, and L is hemodialysis over 4 weeks, and then E was permanent HD. I thought that was an interesting way of approaching renal dysfunction, so just something to think about as we move forward. And then I think it is important to understand juxtarenal, pararenal, suprarenal, and then the different type of thoracoabdominal aneurysms. So understand the morphology of the thoracoabdominals, and that page 3 really showcases those pretty well. So that's something when you're reading a CT scan, you should understand a CT angiogram to understand the different types of morphology of aortic disease. And, typically most of our aneurysms that we deal with are infrarenal with some element of EC, okay? Then obviously the patient characteristics you saw, it's mostly an older patient population, in your 60s and 70s at least. Majority were male, right? And so those are things that we would expect.
Yeah. Right.
And then, the bad complications that were with associated mortality were spinal cord ischemia and renal impairment. So realize those two things have a bad prognosis. So it's important to is it causal? I don't know, but either way, it's something you should be aware of when you're dealing with these patients and following them long term and counseling them on this stuff. So when you see a patient, you have to talk about all these potential complications. And some patients will get scared off, and that's okay. And they should just know the risk of rupture and the risk of these events occurring. And then you have to give them your best advice on what you think they should get. And that's not easy, but that's why this data is important to look at, to be able to counsel patients when you see them in the office. You know, and the other things are, the more proximal, the more extensive your coverage, the more risk of morbidity and mortality is, and that's what the study was suggesting. You know.
Mm-hmm.
I think those are key points. Anything else, Dave or Brandon?
No,
or
I think we covered a lot of it. Yeah.
Anyone else?
Yeah, I mean.
Do you? Oh, go ahead.
Oh no, sorry. Go for it.
No, I was just going to ask Jody. Do you have a lot of experience covering these type 2s and 3s, or like these thoracoabdominal, kind of extensive aneurysms that you're? Because it sounds like this is a pretty, specialized. I mean, because this is
Sure.
usually they do it open, right? I mean, they don't. This
so
is
what
all
we've done is kind of a
a
hybrid approach. We'll put a spinal cord drain in, then we'll visceral debranch them. So we'll hook up from the common iliac to the celiac, SMA, and renals, and so we'll branch. We'll open and then we'll put in an endograft to kind of fix it, so we don't cross clamp and have that stuff. So that way we're kind of, putting a kind of a hybrid approach, and that's been done a lot of, by the Quinones group, and we've been doing a fair number at our facility as well, and it seems to, work out fairly well, in that patient population. So that's what we've been doing. We're going to be doing some components of fenestrated pretty soon in the lab. And so, our colleagues, our multidisciplinary vascular group, it has vascular surgery, cardiology, cardiac surgery, and IR kind of jointly do a lot of these complex cases, whether it's thoracic or abdominal. And so it's really good to have a joint, group to kind of have all the options, including visceral debranching or endoluminal approaches and whatnot, radial approaches, so on and so forth. So I think those are all valuable,
Mm-hmm.
What type of aneurysm are you guys doing first for the fenestrated?
It's going to be, so the IFU for the fenestrated endografts, for the one that Cook has, is that it can be anywhere between 4 and 14 millimeters infrarenal aorta. So you can have as small as a 4 millimeter neck and up to 14 for the fenestrated. Okay, so that's basically where we're starting off with, is someone who has some, and it's technically an infrarenal or almost a juxtarenal aneurysm. Okay, and then you can kind of go off IFU to do some more complex aneurysms as time goes on. And there's different techniques that people can do, including snorkels and chimneys and things of that nature. I know the UVA group that Monica's from, they've done a lot of these kind of techniques as well,
Mm-hmm.
That's interesting. So there's the smallest neck that can be just treated with a normal endograft right now is what, like the ovation endograft can be like 7 millimeters, or is that?
Yeah, no, you're right. So I think the trivascular, I believe you're right, has a very short neck indication up to 7 millimeters. But it's a little tricky because the sealant ring is a certain level below and so on and so forth. So, but if you look at conventional aneurysm sealing, it would be the Endurant that has a 10 millimeter instructions for use indication with the suprarenal stent. So it can do up to 10 millimeters as long as it's not too angulated, has to have an angulation that's like less than 60, I think.
Okay.
So that is the key.
One other question is, because, renal failure was a poor prognostic indicator post-surgically, do you think this would be feasible with CO2?
Yeah, so we have certainly done aortic repairs, the aneurysms, even a rupture with CO2 primarily, and you can use IVUS and CO2 and different things to do that. I think these with the fenestrated branch would be pretty challenging to do that way. Not impossible, but I think it would be definitely a challenge. So I think, standard endograft repair, I think there's ways to do it with minimal dye, if any, if you need. You can do it all percutaneous, you can do local, you can do CO2 and IVUS and whatnot. I think when you're doing with branch and fenestrated, it can be a little bit trickier But a lot of it, honestly, the bulk of this is decided on your pre-op imaging, CTA or MRA or whatever. Most people use CTA, and I think that's a little bit more standardized. And then sizing it and measuring it and figuring out all the angles, so on and so forth. That's 90% of the battle.
Okay, cool.
Good.
Any other questions?
No, I think we covered a lot of topics here. So
yeah, I think it was pretty good discussion on aneurysmal disease.
Yeah.
If anyone has a question, feel free to email us, and we'll try to get an answer back for you.
Cool. Thanks, everyone. That was
Cool.
that was
No
really
problem.
great. Thank you.
Thank you.
Yeah, no problem. Thanks. Yeah. Okay. Take care, guys.
Thank you very much.
All right.
Bye.
Bye.
Thanks.